Hello, everyone. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about strokes. Now, strokes, in my opinion, are one of the hardest, most challenging concepts, at least from a personal perspective, that I really struggled with while going through, I guess, this part of it. I think what makes it really complex is just the wide range of its types, how each one of them present, and then being able to, I guess, arrive at a diagnosis from a collection of vague neurological symptoms. So today, hopefully, we'll be able to break that down a bit further into a format that makes a bit more sense and is a bit easier to digest. So let's start off nice and easy. Basic definitions. What is a stroke? So as you all probably know, stroke basically means there has been an acute disruption to the blood supply of the brain. Now, these can be of two types. You can either have an ischemic stroke where there's a blockage and a hemorrhagic stroke where there's a bleed. Now, it's really important to be able to differentiate the two and know how they present, because when a patient comes in, this is probably the first question you need to ask yourself. On the similar note, we often talk about transient ischemic attacks, which are like mini strokes. So your basic TIA presentation would be someone who came in complaining that they experienced drooping, weakness, something that makes you think stroke, but they have since improved dramatically. It's a temporary disruption and has a relatively good prognosis. But the thing we worry about is, well, why did they have the TIA in the first place? And usually people who have TIAs are at a higher or an increased risk of developing a further stroke in the future. So it's kind of going back to your cardiology. It's kind of your unstable angina versus your full-blown STEMI kind of situation. Alrighty, so here's a good classification of strokes and how they present, where they happen. So starting off, most strokes are arterial. So you need to know that. Most of them, 85% of them, are infarcts or ischemic strokes, while 15% are hemorrhagic strokes. Hemorrhage just means a bleed that can be either in the parenchyma itself or in the subarachnoid space. It is important to know that hemorrhagic strokes have a significantly worse outcome compared to infarcts. With an infarct, you can either have a stroke that's affecting your anterior circulation or your posterior circulation. With the anterior circulation, you can have either total, partial, lacunar, and we'll talk about each one of these. But at this level, I want you to know a few basic facts. Most strokes are arterial. Most arterial strokes are infarcts. Hemorrhages, less common, but worse prognosis. So why do people get strokes in the first place? So if we talk about ischemic strokes, the two broad reasons people might have a blockage would be either an emboli, which means there's been a clot that has dislodged from somewhere else. One of the biggest risk factors is AF and atrial and ventricular clots that might get dislodged to the brain, causing a stroke, and a thrombus. Now, a thrombus means that there has been so the basic premise of a thrombus is you have atherosclerotic plaque buildup, and that ruptures, causing an acute blockage instead of something that's come from somewhere else. With hemorrhagic strokes, your biggest risk factor is hypertension. Subarachnoid hemorrhages, in particular, are associated with burst aneurysms. So people may often have aneurysms, which are these outpouchings and vulnerable sites in their circle of Willis, which we'll talk about, and these often rupture. And when they rupture, it presents as a hemorrhagic stroke. Risk factors, as I mentioned, having atrial fibrillation is a big risk factor for ischemic strokes, versus hemorrhage is anything that puts you at a higher risk of bleeding in general, which would include having a coagulopathy, being on warfarin and other blood thinners, having hypertension. The difference in clinical presentation is relevant. With ischemic stroke, because you've blocked the blood supply to a certain part, it usually would present with focal neurological deficits. What this means is if you have, let's say, an anterior circulating artery stroke, or you've stroked out that particular artery, you would present with symptoms like lower leg weakness, right? Versus a hemorrhagic stroke, which is going to present with more diffuse signs as compared to focal neurology with ischemic strokes. And they might have really, really severe headaches. Subarachnoid headaches are characterized by what's called a thunderclap headache. In terms of treatment, the main differences are obviously approach. If you have an ischemic stroke, your goal is going to be to open up that blockage, which can be done through using TPA or a clot buster, alteplase. And that is usually if the person has come in less than 4.5 hours with their symptoms persisting for less than 4.5 hours. You can also undertake a surgical approach with an endovascular clot retrieval. With hemorrhagic strokes, on the other hand, because it's bleeding, you obviously don't want to give them something to break clots further because that would cause further bleeding. You want to manage their blood pressure and stabilize and basically clip or coil aneurysms. And we'll talk about the differences between clipping versus coiling in a second. So there are a huge number of strokes, okay, and it can get really, really confusing. But let's go back to the basics and talk about anterior versus posterior strokes. So this is our nice circular villus. You've probably come across this at some point in anatomy. You probably forgot about it, and that's fine, but we will recap just the important bits. So your blood supply comes from two broad areas. You have the vertebral arteries, which are these two, and then you have the internal carotid artery, which becomes the middle cerebral artery on both sides. That's important. You also need to know that you can broadly divide this into the anterior circulation, which would be this half, and then the posterior circulation, which is this half. And both of them supply different parts of the brain. So stroking each one of them would present with a unique set of symptoms. What is also important to know are these communicating arteries, which basically join two sides of the vasculature. Now, because of the angles that they're present at, right, they're quite sharp angles. With high levels of turbulent blood flow, they are quite prone to outpouchings or aneurysms. And therefore, a large number of aneurysms occur in the anterior communicating artery and the posterior communicating artery. So those are two sites of vulnerability. These are the arteries I think you should at least know the names of, if not what they supply. The anterior ones, definitely you need to know what they supply. The posterior ones, give and take on how ambitious you want to be. So middle cerebral, anterior cerebral, that's the internal carotid, which becomes the middle cerebral. You then have the posterior circulating. You then have the basilar, which is formed by the joining of the two vertebrals. And then you have the cerebellar arteries, and you have three of them. So you have a superior one, that's just the superior cerebellar. And then you have two inferior ones, one anterior inferior, one posterior inferior. And that's just a representation of where the carotid, where the internal carotid from the common carotid and the vertebral arteries arise from. And that's the arch of the aorta. Now, in terms of vascular supply, here's a really good diagram that I like to go back to. With your anterior circulation, we know we have the two main arteries being the anterior cerebral and the middle cerebral. And the middle cerebral supplies the superior lateral cortexes bilaterally on the same side as the artery, of course. And then you have the anterior cerebral artery, which supplies the anterior part and most of the medial cerebral hemisphere. You then also have the posterior cerebral artery, which supplies some of the lateral parts, but mostly the occipital cortex. Now, talking a bit about, so we talked about what part is supplied with what. Next, we talk about which part of the brain does what, and then we can link the two together to put the stroke syndrome with the symptomology. So this is the homunculus module. And we have a somatosensory cortex and a motor cortex, right, which are going to be here and here. This is a representation of what part of the body is supplied by which part. So this is the lateral part, which is this one. And as you can see, the lateral part is supplied by the middle cerebral. So all of this part, let's say, and this part is going to be MCA territory, or middle cerebral artery territory. Right? Which means that your hands, your face are going to be MCA territory. Now, what does this mean? This means that if we were to hypothetically stroke out the middle cerebral artery, we would lose both somatosensory and motor cortex action for the upper limb and to the face. Versus, if we go back again, we have the anterior cerebral artery, which, as you can see, is supplying the superior part. That is going to be affecting predominantly the lower limbs. And here's another picture just showing the same thing. We have the anterior cerebral artery here, MCA territory here with PCA. You then also have the anterior choroidal, which we'll talk about in a second with lacunar strokes. But at this point, all I need you to know is that the MCA supplies the lateral, ACA supplies the medial, and MCAs usually present with focal neurological signs in the upper limb and the face, versus the ACA, which presents with focal neurological findings on the lower limb. Also important to note, because both motor and sensory fibers decussate or cross over, stroking out one side is going to lead to deficits on the other. So it presents with contralateral motor weakness. That just means weakness on the other side. Hope that made sense so far. Now let's talk a bit about lacunar strokes. Now this is where things start to get a bit tricky. Now, so up till now we had these nice thick, where do we go? We had these nice thick arteries, and usually we would have a thrombus or an embolus that just comes and clogs this, right? And then obviously you're not getting any blood down the tract. That presents with your typical strokes. Lacunar strokes are slightly different, because now instead of having just blockages to one of them, you are having hundreds of these clots or tiny bleeds throughout the lacunar area. And these stroke out the deep internal structures. These namely include the thalamus, the internal capsule, and the basal ganglia. Now, because these are mostly hemorrhagic in nature, they're not really ischemic, one of the biggest risk factors for lacunar strokes is having hypertension. When it comes to learning about the features of lacunar strokes, it is so confusing to just read through a list because it does not make sense. If you read a list, it says it can present with this or that or this or that. A combination of A, B, or C, D does not make sense. So let's break it down into something that hopefully does. Now we know that a lacunar stroke can basically stroke out either the thalamus, the internal capsule, the basal ganglia, or a combination of any of these. So we need to talk about the functions of each one of these to then understand how these would present. So what does the thalamus do? The thalamus receives sensory inputs from the other side of the body before relaying it to the somatosensory cortex. So let's say your right thalamus is receiving inputs from the entire left side of the body and receiving sensory inputs. The internal capsule has two limbs, an anterior limb and a posterior limb. The posterior limb just works with the thalamus. Okay, fairly straightforward. The anterior limb, instead of carrying sensory fibers, carries motor signals now down from the motor cortexes to the medulla and then to the corticospinal tract to go supply all the muscles in our body. The basal ganglia has a really important role in balance and coordination for that side of the body. Now, just based on that, you can see how a lacunar stroke can present with a wide range of symptoms. So let's say you stroke out the thalamus and the posterior limb of the internal capsule, you're going to have contralateral sensory loss, right? Because as you can see, the thalamus receives contralateral sensory inputs and the posterior limb works with the thalamus for the same stuff. So thalamus and posterior limb equals contralateral sensory loss. If you stroke out the anterior limb of the internal capsule, you would have contralateral motor loss because that's what the anterior limb does. If you stroke out the basal ganglia, you will present with balance issues on the same side of the body or on half of the body. And the weird medical complicated term for that is ataxic hemiparesis, right? With the lacunar stroke, you can present with either ataxic hemiparesis, contralateral motor loss, contralateral sensory loss, or a combination of any of these three. So If I told you that you have a patient who's come in with contralateral sensory loss and ataxic hemiparesis, you would tell me that, Karan, you've probably stroked out the thalamus, the posterior limb perhaps, and the basal ganglia. So this is a lacunar stroke that spared the anterior limb of the internal capsule. That sounds very complicated, but if you understand what each part of the deeper internal structures are doing, it makes it super easy to understand. And how we treat them conservatively in most cases with blood pressure management. Basilar artery strokes. Now, when we talk about stroking the basilar artery, we need to talk about what it supplies. Well, it supplies most of the posterior circulation. You obviously have blood supply that's coming from the posterior cerebral artery and the posterior communicating arteries, but we won't talk about that just yet. So as you can see, here is the basilar artery. If you stroke that, you would affect the medulla, the pons, and the corticospinal tracts running down. Now, you will firstly present with cerebellar ataxia because you've shot the cerebellum. As you can see, you have a whole bunch of cerebellar arteries that are coming from all the parts after this. That's obviously not going to be good. But you're also going to have global motor loss. Why? Because you've taken away pontine and medullary blood flows, and you know that the entire corticospinal tract, which is responsible for motor signals, runs through them. And one of the things you would be affecting would be the corticospinal tract. But the really scary thing about basilar artery strokes is that your conscious state is not affected, right? Because you've not affected the cerebral hemispheres, your consciousness is still intact. The frontal lobe, where most of your thinking and consciousness is untouched. So you have a situation where you can't move anything, right? Because you've had global motor loss. But at the same time, you're awake, you're alert, you can see, but you can't speak, you can't move. And that's called locked-in syndrome. And personally, I think that's the worst one to have. So now let's talk a bit about brainstem strokes. So far we've talked about focal ischemic strokes with ACA, MCA, and PCA. We've talked about lacunar strokes. We've talked about basilar artery strokes. Now let's talk about brainstem strokes and how are they different from the ones we talked about earlier, specifically the cerebral cortical ones. We know with anterior circulation, you're going to have focal neurological deficits, so weakness of the arm or the leg or the face. With posterior circulation strokes, you might lose your vision because you're affecting the occipital cortex, but you mostly would have errors with your cerebellum. And that is represented by the Danish acronym, so DANISH. So you present with dystidiokinesis, ataxia, nystagmus, and intention tremor, slurred speech, and hypotonia, all signs of cerebellar hypofunction. However, stroking out the brainstem is a bit weirder, in my opinion, because it presents with generalized features that don't really make sense unless you know what's going on. And a lot of them do involve cranial nerves as well. So let's try to make sense of that. Here is your brainstem, right? You have different parts. You know that different parts are the midbrains, the pons, and the medulla. And you have a whole bunch of these arteries. So the main ones that are good to know are the anterior spinal artery, the posterior spinal artery, and the vertebral artery. So very simply, these three: posterior spinal, vertebral, anterior spinal. Hope that makes sense so far. Just stay with me. To make this simple, we talk about the rule of fours, and let's talk about that. You know that the brainstem is divided into three parts. You have the midbrain, the pons, and the medulla, right? Three different parts. So you know you have 12 cranial nerves. So the rule of four states there are 4 cranial nerves per section of the brainstem. So 4 times 3 is 12. The cranial nerves that are divisible by 12, so 3, 4, 6, and 12 are midline, while everything else is lateral. Stay with me. The 4 motor syndromes are midline, and the 4 sensory syndromes are to the side, or they're lateral. So let's look at this. Firstly, So these are just the cranial nerves. 1, 2 are up above the midbrain, so we don't talk about them, but let's just say they're still there. You have 3 and 4. Again, they divide by 12, divisible by 12. Midline, 6, 12, all midline. Everything else is to the side. So 5, 7, 8, 9, 10, 11, all to the side. The 4 medial tracts are the motor tracts, or the corticospinal ones. The medial longitudinal fasciculus, which does motor movements of the eye and lateral gaze. The medial lemniscus pathway, or the dorsal column medial lemniscus pathway, is the entire name, that runs posteriorly and is responsible for vibration and proprioception. And the motor neurons of cranial nerves. All of these structures, arise in the midline. So how would these present? If we were to affect something in the midline, how would that present? So affecting the motor tracts would present with a hemiparesis, right? Because you lose motor tract control. If you stroke out the medial longitudinal fasciculus, you would affect the movements of the eye and lateral gaze. If you affect the medial lemniscus pathway, you would lose vibration and proprioception on the contralateral side. And if you affect the cranial nerves, you'll obviously present with a palsy of cranial nerves 3, 4, 6, and 12. Now talking about the structures that arise from the sides, you have the spinothalamic pathway responsible for pain and temperature. You have the spinocerebellar pathway for rapid alternating movements. You have your sympathetic chain and sensory neurons of the cranial nerves. The ones that are really important to know, in my opinion, from this, you need to know 1, you need to know that the motor tracts are medial. You need to know that the motor neurons of the cranial nerves are medial. If you don't know 2 and 3, I'm sure you can still figure out where the stroke is, but know 1 and 4. Same with this. I think it's really good to know about the spinothalamic pathway, pain and temperature being lateral, and the sensory neurons of cranial nerves also being lateral. Here I have a list that you can come back to whenever you want about the different vascular territories. The posterior inferior cerebral artery, superior cerebellar, anterior inferior, if you'd like to. But we'll work through these, and if you kind of apply each one of them, you can figure out what's going on. Let me give you an example. So we have a few questions and cases to work through, so we can together apply the rule of 4 and hopefully understand brainstem strokes once and for all. So let's start nice and easy. Or actually, starting off a bit hard. We have a 67-year-old male who presents to the office with a 4-hour history of diffuse motor weakness on the entire left side. He's unable to move his eyes laterally towards the left, which of the following best categorizes his stroke. So firstly, let's just forget that we were studying about brainstem strokes. I see 4 hours of diffuse motor weakness on the left side. I think, oh shit, that's not good. This is a stroke. Now, it doesn't seem like one of our normal ACA, MCA strokes, because I know that those would affect either the hands or the legs, unlikely to affect the entire left side, right? Now, when I think an entire left side is being affected, which is a hemiparesis, could this be a lacunar stroke? It could, absolutely, and that would fit, but then he can't move his eyes. That doesn't fit in. I'm thinking something cranial nerve, and now I think, oh, hemiparesis with cranial nerve screams brainstem. So, okay, let's go back to brainstem. Let's assume this is a brainstem stroke, and let's try to work from there on. Okay, so we know he has a 4-hour history of diffuse motor weakness on the entire left side. We know that his motor system is short, which means that the stroke is going to be medial. Remember, motor, medial. So it's not number 4. Cool. We know that he shot his entire left side, which means that the stroke is on the right, which means that it's not 1 or 3. Just based on that, you've already got to the answer, but let's figure out a bit more. He's unable to move his eyes laterally towards the left. Now, if you go back to your cranial nerves, you know that moving eyes laterally, or abduction, is done by cranial nerve 6, right? Now, if you go back to our nice little diagram over here of the cranial nerves, we ask ourselves, well, Karan, where would cranial nerve 6 be? 3, 4, 6. So 6 is going to be in the pons. So it would make sense that this man has had a right medial pontine stroke. And there you go. And you've done it. So it seems quite complex, but once you remember the rule of fours, it's really, really easy. And each one of these strokes will have some weird name based on who discovered them first. So lateral medullary strokes are called Wallenberg's, but you don't need to know that at your level, at least. As long as you can pinpoint where the stroke is to the side, whether it's medial or lateral, and to which part of the brainstem, that's all you need to know. And that's your answer. So let's say, so in order to understand the symptoms and detect and defects, a doctor must know the anatomy of cerebral vasculature of the region affected by the stroke. Which part of the brain does the middle cerebral artery supply? And I hope that most of you remember that this is going to be C, which is the superior lateral aspect of the cerebral hemispheres. The three main branches of the internal carotid, the ACA, MCA, and anterior communicating, together form. Take a moment to pause the video. Answer. It's going to be the anterior circulation. Okay, so another big one. And I know these big problems can be really daunting to look at, but I promise you, just stick to it and it will make sense. So we have the 67-year-old male who presents to the office with a 2-hour history of, they all present to the office, with a 2-hour history of altered mental state. He was found unresponsive on the couch while watching Jeopardy. You can obviously tell that this was written in the 90s. On physical examination, you note 4 on 5 motor strength on the left lower extremities, not bad. 0 on 5 motor strength on the right lower extremities, kind of bad. 5 on 5 motor strength in both upper extremities. So just based on this, I'm thinking, well, this man seems to have had a stroke. And as I can tell, it's quite focal. So this man obviously has deficits in the right lower limb, while everything else seems to be fine. He has intact sensation to all facial muscles, able to puff out his cheeks, swallow, smile. Gag reflex is intact, no tongue or uvula deviation. So the reason we're doing all these, we're basically doing a quick cranial nerve exam to check if we can spot any cranial nerve defects, which we can't in this case. So lower limb weakness on the right side. We know that he probably has stroked out the contralateral side. So it's going to be a left-sided stroke. And you know that the lower limbs are supplied by which part? This is where you'd be saying the ACA, or the anterior cerebral artery. So this is going to be a left ACA stroke. So how do we actually treat them? So investigations, we like to do a BSL because hypoglycemic episodes can often be a mimicker. You want to do an ECG for arrhythmias because you know AF can put you at a high risk of embolic strokes. In terms of bloods, a thrombocytopenia can cause hemorrhagic strokes. So that's important to know. And you need to know that having an anemia is contraindication for thrombolysis, which is why you need an FBE. UECs, electrolyte disturbances, can cause arrhythmias, and you also need an eGFR greater than 30 to perform a CT with contrast. In terms of imaging, which is where the bulk of our gold investigations are, we have a non-contrast CT, which is going to be the first thing we order. Why do we do a non-contrast CT? Well, you might be asking, Karan, a clot's not going to show up on a non-contrast CT. Well, I would absolutely agree that it probably won't. But what it will show is if the person has had a hemorrhagic stroke, which is the first thing we want to rule out, because that's going to lead us down a completely different pathway, right? Once we do that, we can then do a contrast CT with angiography. Angiography basically using contrast to observe the patency of the vasculature and see if there is a blockage in the vessels. It can also tell us how much of the tissue is dead, and that's called the umbra, versus how much can be salvaged, called the penumbra. And this umbra to penumbra ratio is really crucial in seeing how aggressive we want to be. If we have minimal umbra with a lot of penumbra, looking at that ratio, we might think to ourselves, well, we can still save a lot of this. So let's go a bit more aggressive. Versus if you have vast majority of the tissue being umbral tissue with no penumbra, that's a bit more concerning. You can also do Dopplers and echoes, especially of the carotids, to identify a thrombus if you can spot one. In terms of treatment, our gold standard treatment for ischemic strokes is going to be orthoplase or clot buster or tissue plasminogen activator, all the same things. And that's going to be given within 4 hours of onset of symptoms, and it's given IV. Apart from that, all patients should receive SABC. That's statin, aspirin, beta blocker, and clopidogrel. You can also do a surgical endarterectomy, which is the retrieval of a clot if they have a greater than 70% occlusion. However, if the stroke is a hemorrhagic stroke, our options are very limited. It's mostly BP controlled using beta blockers and high intensity neurocritical care, the specifics of which I'm not particularly familiar with, and I don't think you have to be either. And here's a really good diagram that I've taken from AMBOSS that really talks about the entire pathway of what investigations to do and what our treatment of choice is going to be. I hope that all made sense. I know I went on for slightly longer than usual, but I think this is a really important topic to understand. If you have any questions about strokes, how they present, or any explanations that you'd like on top of what I've said, please feel free to get in touch. I'm always happy to answer questions. And as always, please look after yourself and please look after your loved ones. I'll see you guys in the next one.